Thanks so much for the invitation to talk about one of the viruses that I'm very passionate about for multiple different reasons. So hepatitis B virus. And so I'll talk about a few things here today. I actually have a more basic science talk later today, so I decided they're two different talks. So this one is mostly going to be on the public health type component. So I'm going to try this with a slide advance. Let me just see one version.
It doesn't work, I'll do it.
Okay, then if you could do that would be great. We already did a land acknowledgement, but I always like to go with anyway. We are Treaty 6 territory, unceded nation, lands of the First Nations and Métis people. I have a few objectives that I was asked to submit ahead of time, so I'm trying to keep to these here as I go through. I'll tell you a bit about the epidemiology of Hep B in Canada and worldwide, and where we are with some of those WHO elimination goals for hepatitis. And then I'll talk about some of the gaps and challenges and a couple of projects that we're getting going with our group.
It's not working, eh?
It is? No? Okay.
There you go. Yeah, you got it. I think you just need a mouse pad.
There. Oh,
there we go.
There. All right, we're going. Okay, if it keeps moving, I'll just talk faster. It's all good. Okay. So hepatitis B virus currently infects over 296 million people worldwide, and to put the Canadian focus on it, about 300,000 Canadians. You can see kind of with the heat map here, kind of the predominance of where some of these higher rates of infections are. And locally, certainly in Canada, we do have limited data. We're not actually so great at capturing all of that information here. Just move this to the side. So in Canada, we have variation even amongst the provinces, even in terms of being able to monitor these things. One Canadian survey suggested that, you know what, actually, we're probably not doing so great. And there's probably about 50% of people that aren't even aware that they have infection. Throughout Canada, of the places that we do have some fairly rigorous monitoring, we can see, okay, the variation just even in the types of genotypes that are found across the board. And what some of that implies is, you know, there's some links to how the disease progresses in terms of how people respond to medications, for example. And so having a lot of the surveillance and these sorts of things have implications that way. Amongst the cities across Canada, even, you know, Edmonton and Calgary, of course, we still have within our populations, there's a lot of variation. And so depending on where a lot of our immigrant populations have come from, that typically leads to what sort of genotypes are found. And of course, around the world, a very large variation of where different genotypes are found. Generally, there are little pockets and regions where some are found more than others. And just to give a bit of a sidestep commentary, because as I was putting this up, I was like, okay, the whole genotype tracking and that sort of thing is really great when you want to, you know, go back in time and find out, you know, when people shifted between countries or did different things that way. And I was just thinking, you know what, this type of a map is not going to be able to occur anymore. We have so much cross-travel spread and whatnot. A COVID map, even in the span of a few weeks, we had strains from one end of the world completely to the other, and then it completely covered the whole world. And so some of these sorts of maps of molecular clocks and working back in time, it's almost very different. These are the travel that would have taken place with a lot of the development of these sorts of things. It's in the past now. We have so many more ways of getting around and traveling, and so any infection and any condition in one country is only one flight away from showing up here on our doorstep. And I think that's one of the things I just like to always kind of remind people when we talk about these things, you know, even things that we see locally, even, you know, being aware of things that are happening around the world, you know what, it's only one flight away to becoming part of what's happening here. So hepatitis B, it is a silent killer. I'm going to kind of talk a bit about some of that as well. But this virus has the ability to cause liver cancer as one of its routes of mortality, as well as liver failure. Now, with an estimated annual mortality rate of about 820,000 deaths, that is not insignificant. Why it's a silent killer is because the virus doesn't actually cause many symptoms or any symptoms until late stages. And so you can be infected with hepatitis B and your liver is otherwise functioning well, is healthy, having no troubles, but it can progress to inflammation and then scarring or fibrosis. And if that scarring builds up and it's not reversed or it's not treated, and it can progress to cirrhosis. And when someone reaches the stage of cirrhosis, they have a 15 to 20% chance of developing liver failure, decompensation, which over a span of 5 years, different studies showing kind of the rates of how quickly that can progress.
Here's a mouse pad. It'll make it work a little better.
Thank you.
Here you go.
Excellent, thank you. And so liver failure being one of those routes of progression, but also liver cancer. And again, once you reach the cirrhosis stage, 15 to 25%. Now, hepatitis B, unlike hepatitis C, has a unique route, sort of a shortcut from going from a healthy liver right to cancer. And that's one of the things that has different implications from some of this stuff. So it's able to actually integrate into our genome. Now, once it integrates, it's not actually a functional thing, but it can still, if it interferes with an oncogene, for example, it can sort of skip that whole process, leading to liver cancer by a very different route. And that is not insignificant either. So 1 to 3% over 5 years. So this has implications for many different things as well in terms of monitoring, and even people who are healthy should still have monitoring for these sorts of developments. The thing is with monitoring is we can do stuff about it if something is found, and that's part of the point. So things that put someone at greater risk of developing these sorts of complications are age, sex. So if you're male versus you're more likely to develop some of these things versus female. Alcohol use, flares of liver inflammation. As well as viral factors. So this is where the genotypes come into play, so as I was mentioning, but also viral loads and co-infections like with hepatitis delta virus or with HIV or HCV, which certainly is their similar risk profiles for some cases. Around the world, hepatitis C causing hepatocellular carcinoma or liver cancer, again, showing some of the higher predominance areas here. And in low-income settings, most people with cancer, with liver cancer, die within months of diagnosis. And in high-income countries, where you can get treatments and detection and chemotherapy and surgery, you can prolong life for several months to a few years. So it's a very serious sort of outcome for a lot of these things, and very real for many people who are living with chronic hepatitis B. So the World Health Organization released a report in 2016 looking at their strategy for elimination of viral hepatitis. So this included both hepatitis B and C. And they had laid out various goals for what they wanted for around the world to have targets. So this was based on 2015 numbers and whatnot, and they wanted to kind of, the targets, many people said perhaps a little bold, but you know what, if you don't aim big, you don't reach or get the push to go for these things. So 90% reduction in new chronic infections and a 65% reduction in mortality compared to the 2015. That doesn't sound like or that sounds like large numbers perhaps on some scale, but as you can imagine, there's a lot of things that get mixed in with this, including, having to have public policy buy-in and having people accept some of these approaches and having the bandwidth. I mean, if you're in a country where you're dealing with an Ebola outbreak and then civil war on one side and refugees streaming in, I mean, I can only imagine how some of these challenges would actually come into play for many countries that are dealing with these sorts of things. So in terms of those goals, though, the different things like prevention, getting vaccination on board, birth dose vaccination, getting people on treatment who need it, and trying to reduce mortality. Essentially, there are some targets that are being met by some countries, but no country is anywhere near reaching their 2030 targets for what the WHO has set out. Okay. That's meant a bit on the more negative side, but I also like to end or stream towards the more positive side and kind of, empowering people, what there's things that we can do. Yes, there are lots of gaps in hepatitis B research. There are lots of challenges that come with it. from all ranges of the thing, but it's the virus itself, in terms of, strategizing and kind of ways of figuring out things that will have public health implications. I'm going to tell you about a couple of projects here. But first, just a quick word on the virus itself. I had mentioned that, yes, it is a silent virus. And what makes it silent? Well, there's a lot of things, from the virologic sense, the virus itself, clinical sense, and the social sense. So I'm going to describe them in this order here, to kind of go forward from here. But from the virologic sense, it is a stealth virus. It actually doesn't trigger your interferon system. It doesn't let you know that it's happening. And so I've got this is a study from one of our colleagues here at the University of Alberta, Dr. Connie Lay, doing her PhD, this is a single cell RNA-seq data. So for those of you who are familiar with this sort of thing, I'm not going to go into the details of it, but just as a snapshot, you can look at sort of some of these sorts of things here. So this first panel, usually I can get let's do the, I don't think people can see. Oh no, maybe you can see my mouse. Excellent. We're going to keep doing that. As long as I shake it, it doesn't disappear. Okay. Okay, so this first one is mock infected cells. So this is a type of, for those who are interested, HUH 7.5 NTCP cells that set up. And these are infected with hepatitis B. And just glancing at it, you barely can see a dip. Like there's nothing really happening. If you then if you give interferon to those cells, you get this sort of a pattern. And then if you give interferon and hepatitis B, very similar. So hepatitis B does not do a lot of distortions in terms of what's happening there. It gets in, it evades a lot of things, and it just quietly gets in, gets set up. Makes it a very, very a quiet virus. So in a clinical sense, it is also silent. As I mentioned, people can have this for years and decades without having any signs of any symptoms. And so that's one challenge of it. So if people don't know that they have it, how can they even kind of get interventions for it or get monitoring for it? And that is a huge challenge for a lot of people. It also spreads asymptomatically. So mother to child transmission is one of the most common modes of transmission. And one of the reasons why birth dose vaccination is so important. Because again, you wouldn't know if you didn't test. And in the social sense. So this is probably one of the bigger challenges, of course, with, the maps that I showed had much darker predominance in areas where, countries with lower socioeconomic status, lower ability to do these sorts of things. In Canada and the US, the predominance is in immigrant populations. And as many of you know, they're the population that has less of a voice, less of an advocacy for their own health and even just navigating our own system. And so there's a lot of issues even just from that alone. And then the stigma. This is probably another huge one that still pervades society. The stigma that's associated with bloodborne illnesses and modes of transmission. And I will say there has never been an infection in history where stigma has helped fight and ward off an infection from leprosy, from polio to HIV. I mean, the stigma that gets associated with infectious diseases is just horrendous, and it doesn't help control things in terms of getting things under control. People hide it. People kind of, don't seek the care that they need, and so many things that get associated with that. And then there's still ongoing myths and misconceptions. So even here in Canada, even amongst my medical colleagues, there's still a lot of misconceptions about, hepatitis B and what we can even do to treat and what we can even, from there. And so every time I get a chance to give a talk about hepatitis B, I always accept. So that's one of the things, because anytime anyone's listening, it's one more chance that maybe someone else hears some of the message and kind of going from there. So. And so I'm going to tell you about from the social sense and kind of from kind of going from that side of things and some public health sort of directed projects that we're trying to get ramped up here. One of them here is in Canada. One of them links us with Mauritania. And so I'm going to tell you about those here now. So with vaccines and timing of use. So I'm going to quickly touch on that. So vaccines, the risk of chronic hepatitis B. You know what? I didn't actually look at the time. You got to tell me if I'm running long too. So the vaccines are very effective against preventing transmission of hepatitis B. If you are exposed as a neonate, you have a 95% chance of developing chronic hepatitis B. If you are exposed as an adult, it's only about a 5%. So it's very age related in terms of what that looks like. But this is why we should have birth dose vaccination, because if you get babies vaccinated right at birth, they have actually a chance of not getting it. And so that's one of the things, and it's one of the recommendations from the WHO. If you get birth dose vaccination, and I'm throwing out these terms here with E antigen negative, this effectively means replicating virus and actively replicating high-low levels. If you have lots of replicating virus, you go from a risk of transmission to your baby from 90% down to 21%. That's impressive. Like even from having such high levels, if you are E antigen negative, so lower levels, 30% down to 2.6%. So just that one intervention alone, birth dose, has an immense impact. If a country or is able to have immunoglobulin, so hepatitis B immunoglobulin, you can decrease that risk even further. So you go from 90 down to, if you give both immunoglobulin to mop up the extra virus, and then you give vaccine, you go from 90% down to 6%. That's phenomenal for something that would otherwise kind of be a guaranteed sort of exposure for a child. And then 30% down to 1%, or sometimes even less than 1%. So there's some impressive things that we can do when we know about it and we check. So how are we doing in Alberta? So before 2018, we would vaccinate children in junior high, and so 2-dose vaccination regime in junior high, which is fine if you've never been exposed all the way along. But if you've had exposures from earlier on, the vaccine is not going to do much for you that way. Now, since 2018, we've gone to the 2-month time frame, so that we're doing it a bit earlier. So we're getting there, but we're still not quite there. And across Canada, there's only 2 provinces. Actually, PEI is now on the New Brunswick. PEI and New Brunswick are both doing birth dose, and then Nunavut and Northwest Territories. So 2 provinces, 2 territories. Everyone else has various ranges of when they're giving the doses, and so technically they're still not following WHO guidelines. Why is this an issue? Well, if it's, our vaccination program is so effective in Canada, we shouldn't have data like this. So this is a study that was done in Ontario, where they looked at Canadian-born and foreign-born people who are children who are being treated with for hepatitis B. Now, foreign-born, while it's unfortunate that they hadn't been able to be captured, but we wouldn't necessarily be able to intervene with birth dose vaccination for foreign-born, so people who came to Canada. But for those who are Canadian-born, this is where the numbers I find are shocking. So that means that 139 people who were born in Canada contracted hepatitis B while in Canada, despite the fact that we have all of these other measures that we can do to help prevent transmission. While as a network of the Canadian Hepatitis B network are advocating for pushing birth dose vaccination across the country, we're not quite there yet. But this brings me to one of the projects that trying to get set up, and I'm partly stating it here again. I think I might have mentioned it at a previous talk, and it's like, oh no, I haven't gotten all the Research Ethics Board stuff through. So I'm partly stating this to hold myself accountable, but just to also see, kind of getting people to kind of help push this forward as well. But doing the same sort of study that was done in Ontario and doing it for Alberta. Let's find out what our numbers here, because if we don't have the numbers, we can't advocate as strongly for these sorts of things. And that's one of the challenges with going to policy programs and trying to make changes that way. So, like I said, someone's going to hold me accountable. And the next time I give a talk, if you ask me to give a talk, I'm going to tell you about what those numbers are. I'm going to tell you what we've done to make the changes, try to get that happening in Canada. Okay, so now I'm going to tell you about another project that spawned from an email last summer from a PhD student from Mauritania. He had reached out to me about doing a collaboration project. So I'm just going to give a bit of a background with Mauritania and where things are with hepatitis B. So in terms of positivity, the numbers are not really well documented or known, but we think it's probably around about 9.2% of the population with chronic hepatitis B. In some cohorts, they go up to even 18%. So they're looking at different populations for those that have been able to do studies. HPV-related deaths specifically, 11.5 per 100,000. In Canada, it's 1.1 per 100,000, just for comparison. Mauritania has adopted the birth dose vaccination policy in 2013, which is fantastic. We don't have any data on how much is actually being done and covered though, so that's not quite clear. Healthcare workers are not currently being screened or offered vaccinations, although there are some pilot studies that are looking at that. So I came across the study recently in 2023. So that's fantastic that they're able to move some of that forward. And only about 7% of eligible people are currently on treatment. So there's a lot of things there from that front. And then, so this student, CD Buna, had reached out and said, you know, I will do collaboration with you. I want to get more data on this stuff for my country and that we can actually do something about it. And so just his drive and advocating for getting some of this stuff moving forward is you know, well, first off, we had to say, okay, what did you ask your supervisor that we could actually do all of this stuff first? We had to get all these things coordinated, and then we eventually kind of worked out all the research ethics and got some samples sent to. So we actually have been able to get started with some of these things. But just in discussion, so when they do diagnosis for hepatitis B, they're essentially doing PCR test where they're doing, or they isolate the DNA, they do a PCR test, and they compare it with positive controls on a gel. So they're not doing sequencing to be able to tell this stuff. And so one of the things that, one of the reasons he reached out to me, because I had some previous work with a group in Ethiopia, we did some of the similar sort of work. But what we can do when we've got the ability to do sequencing is we can check 2 sections of the virus. And one of them, we can tell the genotype and vaccine escape mutants, looking for all the different sorts of things here. And if we check this other section, we can get drug resistance mutations and high risk hepatocellular carcinoma mutations. So for those of you that can think of what that might be or what lead to for public health implications. So and for the genotype and the high risk HCC, as I mentioned, there's some links to liver cancer. If you have lots of this this type of strain circulating, well, then maybe that implies you need to do more screening more often. If you've got vaccine escape mutants, oh goodness. So if you've got the birth dose vaccine is your way of preventing mainstay of transmission. If you've got vaccine escape, your vaccine's not going to protect your babies, but maybe you can get mom on drugs and get her viral loads much lower to lower that risk from the get-go. Again, you don't know what's there, you don't know what to advocate for, and so having a look at some of these things. And then drug resistance mutations. So often, if people have a diagnosis, we often don't check all of these different things in Canada. We check drug resistance for HIV, but not for hepatitis B. We go right to our first line drugs that have low barriers of resistance. But for a lot of countries where they use some of the first line is lamivudine. There's a lot of lamivudine resistance that are occurring. And I believe Mauritania does use tenofovir, so that's at least a good thing from that front. But I partly want to pull this up because our research team, while we do all kinds of different things, here is one of my students is here with me today. We've got we do a lot of work on the pathogenesis of hepatitis B, looking at different pathways, drug development, all kinds of different things that way. And then the incorporation of all of this, it still has direct implications. But that is just one part of it because the whole thing it's connected. We have all of these different public health implications that, kind of taking a lot of the stuff going forward. So it still remains a concern worldwide. There is an effective vaccine, but ideally has to be given at birth. And then global health contributions can be done locally. It doesn't mean you have to fly around the world to contribute to global health. If we can help these folks in Mauritania, kind of maybe they can get some of that data. They can then, like his thesis, will then help for public policy. We can go to the government and say, you know what, we have these issues. Maybe we can do this sort of thing. And so a lot of the time we think, okay, well, I wouldn't have time to commit to go across to doing all of these sorts of things, but there's lots of things that we can do from all of this front. And I brought up CD's project and all that because I'm also looking for funding for maybe getting him if he wants to come over and learn how to do some sequencing and stuff. So it's a bit of a plug for anyone who's listening. I'm putting in grants to see if we can get him over here to join our group for a couple months and process all of these extra samples that he's now accrued from his PhD. And then lastly, for everyone here and everyone online, learning more about hepatitis B, both for yourself and for others, because if we can kind of decrease the stigma, increase the knowledge around it, that already is a huge part of advocacy. So thank you very much. And if there's time, because I probably talked a lot, if there's time, I can answer questions.